Thank you all for coming to this session. This session is being taped, so we will be bringing mics around if you've got questions, so that we pick up your insightful question that you have for us. And so it is my pleasure to welcome you to the presentation called Using Data to Drive Health Equity at the Local Level. This session is accredited for continuing education. You can check that out on the conference website, a mobile app, or at the registration desk if you need that. Please turn off or silence cell phones, other mobile devices. That would be appreciated. And now it's my pleasure to introduce my colleagues and our presenters. First of all, Chris Thokes brings over 20 years of experience working in public health and nonprofit sectors. She's currently the interim division director of the Office of Statewide Health Improvement Initiatives at the Minnesota Department of Health, which is where all three of us are from. This includes the Statewide Health Improvement Partnership, called SHIP in our state, tobacco use prevention grants, and tribal grants. Previous experience that Chris has includes serving as program officer of the Otto Bremer Foundation, a staff lobbyist and senior policy manager for Clearway, Minnesota, and executive director of Minnesota's youth anti-tobacco industry organization, Target Market, which was super cool and did a lot of super cool stuff, and as director of tobacco control for the American Lung Association, Minnesota. She has additional experience working in county and state public health departments, tobacco control, and HIV and AIDS prevention. She holds a bachelor's in community health education from the Minnesota State Moorhead, University of Minnesota at Moorhead, and a master's in public administration from Hamline University. And then we also have with us today Jeanette Raymond. She supervises a community engagement unit for the Minnesota Department of Health and in the public health practice section. This unit's responsible for increasing the capacity of our department and Minnesota's local health departments to authentically engage communities across the state. She serves as a member of a core planning team for the MDH Advancing Health Equity Efforts, hence the reason she's here today to talk with us. She also staffs something called the Minnesota Healthy Partnership. I don't know if she's going to talk about that a little bit more, but it's a statewide public-private partnership that developed the Healthy Minnesota 2020 Statewide Health Improvement Framework, and then most recently, the 2017 Minnesota Department of Health Statewide Health Assessment. So prior to joining the Department of Health, she worked for 15 years on community-based violence prevention initiatives in Hennepin County, and she earned her undergraduate degree from Princeton University and has served in governance roles for the American Friends Service Committee since 1989. So please join me in welcoming our presenters.
Thank you, Susan. Good morning. So we're going to break the presentation up a little bit today into a few big buckets. I'm going to give you a broad overview just for a foundation on what is the SHIP program in Minnesota and what's that look like and how do we approach the work. And then Jeanette's going to talk about our health equity data analysis and the guide, which is our actual tool that we use to do the HEDA, as we call it. And we have piloted that tool and are now rolling it out. So Jeanette's going to talk about that. And then I'm going to talk about a different project that we did with our tribal nations in Minnesota as well to inform our programs. I think that we're going to stop after the HEDA presentation and take some questions about that first chunk of work, and then we'll take questions at the end as well. So the Statewide Health Improvement Partnership, this is a program that we received state funding in 2008, and it was part of healthcare reform. This was the prevention component to healthcare reform, and at that time it was $47 million for the biennium. And then over the years, it's gone, as things do in public health, up and down. It went from $47 million down to $15 million, and now we've kind of held steady at about $35 million. And we provide funding to, in a kind of a couple buckets, we provide funding to, we have 87 counties in Minnesota. We have 41 community health boards. So our community health boards are organized by population. So we have just a handful of like single city CHBs, and then we have some that are multi-county in our state. So we have grants out to our 41 CHBs, and then we have 11 tribal nations in Minnesota, and we are funding 10 of them. The 11th nation is the Shakopee Mdewakanton Sioux, and they actually don't accept any grants as a nation, and they're very resource rich and very generous. They're very interested, especially in the healthy eating space in our state, and they are more of a co-convener and a co-funder in our state as well. So the SHIP program, our focus areas are really around healthy eating, physical activity or active living, and tobacco use. We do that work in the settings of community, schools, healthcare, and workplace. All of that work is done using a community engagement model, and we apply a health equity lens to all of our work. As a backdrop to this, Minnesota is consistently ranked one of the healthiest states in the nation. If you dive into that a little bit, it's not shared by everyone. We have some of the greatest health disparities and health inequities in the United States as well. And so we really thought about, the first several years of work were really just getting the program up and running, get people out and talking in their community. But then we really determined that we needed a more thoughtful, strategic, intentional process to engage communities and to really focus those dollars in the communities that are experiencing the greatest health inequities. And so we worked with our Center for Health Statistics in developing the HEDA, which Jeanette is going to talk about. So really some of the focuses of the SHIP program are forging partnerships among diverse local leaders. So one of the requirements of our grant program is that they are required to have a community leadership team. And Jeanette does a ton of work with them about what does that team look like, who's at the table, how do you do authentic engagement. There are monthly phone calls to just continue to have people use a quality improvement process about how are you engaging your community and who has a voice in your community around this work and to help you focus your work and choose which strategies you're going to work on. Really catalyzing broad-based community action. So we really want folks to be out in the community having conversations. And for lots of our CHBs, these are new skills that they're learning. They're used to running an immunization clinic or child and teen checkups, and to ask them to go out and do one-on-ones in the community and do some community organizing, it was just a really different skill set. So we are trying to provide some really intensive support for them to get out of their comfort zone and have these conversations. Really leveraging local knowledge. So we do have a menu of strategies, and we have implementation guides for the communities, but it's really up to them to look at their community needs and select which strategies they're going to work on and how they're going to really implement that on the local level. All of our work is also through a PSE lens, so policy systems and environmental change. That's in our statute as well, that it needs to be evidence-based and PSE focused. So I'm going to turn it over to Jeanette, and she's going to talk about the HEDA.
So some of you may know in 2013, 2013, anyway, a number of years ago, the Department of Health, Minnesota Department of Health, published a advancing health equity report. And that began to unleash a whole variety of initiatives all over the department. It wasn't really a top-down, it was sort of it grew from all over the place. And Chris mentioned our Center for Health Statistics. Staff in there began to think, what if we really want to analyze our data for health equity, what would we do? So public health generally asks these conventional questions. What is the obesity rate? What groups have higher obesity rates? So we can describe the problem, and we can describe where the problem is, but we stop there. So this process was actually designed to ask these other questions below that line. Why do these groups have higher rates? What are the conditions that create the difference in obesity between the populations? And how can we target underlying conditions and then reorganize policies to ensure healthy environments? So it was really trying to get below the what to the why.
And so people were developing that tool, and there came this opportunity to actually develop and run a HEDA, this health equity data analysis, through the SHIP program. So we created this guide for local public health departments. It's on our external website. You can go and find it. I think, did you upload it, Chris, into the, no, okay, anyway, you can definitely find it. And so the SHIP grantees are actually using this process to collect data from the populations most impacted around the why and the conditions and the causes. So just quickly, it has a number of steps. We first look at what is the connection. So these first three steps are sort of intermeshed. And some people start at it by looking at what are the populations that they think might be experiencing health inequities, and then looking for differences in outcomes, and then looking at the literature. That's the connection step. We have some of the literature posted on the website about what's the connection between poverty and diabetes, what's the connection between education level and smoking. But basically, they look at their jurisdiction and they work with our data people at the Department of Health to identify a measurable inequity. And so I talked about this in the workshop yesterday. So we make a distinction between disparities, which are difference in health outcomes. It could be differences in breast cancer rates between men and women. That's not an inequity, it's a disparity. Inequities are disparities that are grounded in inequitable social and economic conditions. So some of the examples are people have been looking at diabetes rates for those earning $35,000 and less versus those who are earning $35,000 or more in their county, and they've found things like the diabetes rate is 4 times as high for the low-income folks as it is for the higher-income folks. So those are the kind of things that they're looking at. So once they identify the population difference, they've looked at the literature, they go back again and maybe look at the literature again, and they run focus groups or key informant interviews or other ways to collect information from the population most impacted about the conditions and causes. And you can see that community engagement goes through all of it because they're engaging some of their partners in looking at the data, choosing the difference that they're going to look at, and then obviously there's an engagement part in the finding out what are the conditions and causes, and then we're also really asking them to engage the community again in putting meaning to the data they've collected, the qualitative data they've collected, and helping share that then with the community at large. So the goals of the HEDA are to expand the understanding of health. So if you only think that health is because of healthy behavior or access to health care, we're trying to expand that understanding of health to really look at the economic and social conditions in that area. We're trying to strengthen community capacity. This is our Department of Health triple aim of health equity. These are 3 practices that are really important to advancing health equity. This one focuses mainly on expanding understanding about health and then strengthening community capacity. So we want the community to be stronger once we've done the HEDA. It's not just for us to extract the data and use it ourselves. We want to make sure that the community has that data. We're engaging new partners to take action. That's another aspect of engagement. And it is actually beginning to inform future work plans. It's bringing in new partners, new ways of approaching things, et cetera. So we did a pilot, and with 10 of our grantees, we have 41 grantees, and we did a pilot with 10. We sort of put out a proposal saying, how many of you would like to do this? We got 20 applications. So we were able to choose a variety of sizes of local public health departments, geographic distribution, et cetera. So anyway, we did a pilot evaluation, and I will tell you we made a lot of changes between the pilot and this second rendition where we're going through with the rest of the 31 of the grantees. what we learned is that to do this process, we actually had to address these three topics. How many people were in the training around narrative that I did? Anybody? Just a couple of you. Okay. I'll start with, I talked a little bit about engagement already. So as we prepared the second cohort, we did a training on engagement and really had people think about what does it mean to authentically engage the community in this process. We shared learnings from the pilot grantees. One thing that people ran into was there's a very strong story about what creates health. This is the narrative piece. So the story that is very strong about what creates health is access to medical care and healthy behaviors. So even if you ask people from marginalized communities about what are the conditions and causes that create the health outcomes, those disparate health outcomes, they will talk about access to health care and healthy behaviors, like we're terrible, we eat the wrong foods, et cetera. So we actually had to help the grantees design key informant questions or focus group questions and do those probing questions that would get down to the next level of, well, why are those behaviors that way? What are the conditions and causes that get there? So we actually did narrative training with all the grantees to help them understand that there's a frame through which many people will see things and that we need to actually probe a little bit deeper to get to those underlying root causes. And then the third thing was around action. The grantees really felt uncomfortable asking the questions without having a clear idea about what the actions they would take afterwards. And this was somewhat of a problem because SHIP is somewhat prescribed in what it does. But they belong to counties, they belong to bigger health departments, there's other opportunities for action beyond SHIP, and there actually has been different kinds of action through SHIP as a result of these processes. So one key learning from the pilot was really how challenging it is to redirect the narrative in discussing the causes of these health inequities. So here's just a quote from from the evaluation. I feel like HEDA at least started the conversation internally. In the SHIP world, which is this program, when we're talking about trying to address obesity, physical activity, nutrition, it evidently comes back to why don't they just eat better? Why don't they just exercise? It just keeps coming back to this concentration on individual health. So what the grantees really experienced was that really strong pull back into the dominant narrative. And even when they would share the results with their public health colleagues, this is the response they got. Why don't they just eat better? Why don't they just exercise more? So they found that individual health narratives are powerful and persuasive, and it's challenging to introduce these new narratives or expand. Even though we've been talking about social determinants of health for, 20, 30 years, people really don't, in a sense, really don't believe it. So part of this is about creating some belief. They found that HEDA engages community members to frame what creates health and illness. So we know we have these issues, we see it in our quantitative data, but actually sitting down with our community members and hearing from them, it was an emotional aha. One of the stories that I like to tell from this is we had someone from northern Minnesota who did the interview questions with the director of the food shelf. And then she did the interview questions with people who use the food shelf, got totally different answers. And so often in public health, we use the professionals that run the program as our proxy to tell us what the community is experiencing. And sometimes they know, but oftentimes there's a gap. And just a little thing out of that story, one person said, I have asthma, and when I come in here, I have to go through a gauntlet of cigarette smoke. Why is it that at the food shelf, I have to experience that when I don't have to do that in other ways? So they've changed that little policy. That's just a little policy thing, but, anyway, it's just very interesting. Okay. So they also realize they need to examine the approach to engagement and notice who is at the table. I've become more aware that voices are not sitting around the table. The people who are not at the community health, like every local public health department has to do a community health assessment, right? The people who are not at the community health assessment meetings, who are not participating in the HEDA process, just pointing that out to my colleagues and being more aware of it. So sometimes I read something like this and I feel the enormity of the change that needs to happen to actually advance equity. And part of this process actually galvanized and made really real to the local public health folks how little contact they had with their target populations or their focus populations, and how little those folks were at the tables that they were convening. So one of the results of this, well, one of the things that we're trying to do is we're trying to support in this round of community health assessments in Minnesota across the state, utilizing the HEDA data that was collected and integrating that into their community health assessment, but also bringing this ethic of who should be at the table to the community health assessment process. I was thinking one of the grantees now doesn't want to collect any more quantitative data. They only want to do HEDAs. So, like, it was so, the information was so powerful. Moving to action, so creating a shared vision for health equity. Again, this HEDA process is much bigger than any one program like SHIP. It was difficult because we can make changes within our SHIP work, but it should be affecting the bigger public health department. It's hard to make sure you're talking about it enough to make sure everyone's aligned with the same goals. So this is one of the challenges in the way we did this pilot. We focused on one program. It was statewide. But there was a challenge in that it was somewhat compartmentalized, and not every public health director really valued this kind of data, knew what was going on. So we have some work to do in sharing that process, having it impact the community health assessments, and working with our public health directors to expand their capacity to supervise and shepherd something like this. And to that end, we actually have a cohort of six of our CHBs where we're leading them to develop more capacity around health equity practices. All of those processes engage the directors. So we sort of took this, saw a really big gap in our support to local public health departments around equity, and are beginning to fill that gap. So now we're working to implement this health equity data analysis process statewide. You can see the pilots are in the green. We have 3 additional cohorts of the grantees. You can, again, see how they're split across the state. And hopefully by the end of April of this year, all of them will have completed the HEDA and begun sharing those results out to their communities. The sharing results out is sort of tricky. I told this story yesterday. In Wright County, which is sort of the central part of the state, they did some of their information collection from folks that lived in a manufactured home park. And they realized when they're going to share out those results, they're going to be upsetting the power balance in their own community. Because the manufactured home park owner has all the power over the people that live in there. And we're trying to shift that power dynamic so that the people who live in the manufactured home park have more say over the conditions and causes of what creates their opportunity for health. So there was a story early on from SHIP where we were trying to get a walking path that would go by a manufactured home park. The owner decided they didn't want it because it would cost too much to shovel it and keep it clean. So then, the very people that would actually need a better access to walking paths couldn't have it because of the person who was owning the property. So the power dynamics are something that will come up. Let me see. I have one more minute. I want to say one other thing about the power dynamics. There are also power dynamics with our existing partners. When you begin to value lived experience at your partnership tables, people who have the educational experience, the professional experience, will feel threatened. And they will, so you actually have to prepare your professional folks to bring lived experience into the conversation. So one of the things that we're doing in this project is really making sure that the whole process is done with the knowledge of their community leadership teams, who tend to be positional leaders in their communities. We're trying to shift that, but we're trying to bring along their community leadership teams through this process so that when we have the information to share, people are ready to share it. So our continuing questions are, how can we expand this HEDA approach within our own work? How can we expand the collection and use of qualitative data to inform what we do? And then how can we expand this approach beyond our office's work? And for those of you who are going for public health accreditation, you have to have qualitative data sources in your latest community health assessment. So this is one, this has been very good for some of our local public health departments who are pursuing accreditation. And I've talked a couple of times about how the HEDA can inform local community health assessments. So I'm going to stop there, and I want to see if there are questions. I've given you a very high-level overview of this process and what we've found. But if there are a couple of questions right now before we move on. So there's one back there. If you can wait for the microphone. Do you see it right back there? Raise your hand higher. Yeah, there we go.
Thank you. I was just wondering if you could speak just very briefly about the type of data that you're getting from this. You've described it as qualitative and said that some of the public health directors are having a hard time actually accepting it in comparison to the quantitative data. And so for me, it would be really interesting to hear what sort of qualitative data, like what are the actual results that you're getting from this analysis?
Yeah. So, so if you look at, I'm not going to be able to pull these off all off the top of my head, but for instance, the diabetes rates between low-income, high people. And so some of it is access to food, some of it what is offered at the food shelf, some of it's transportation, because people can't actually physically get to there. A lot of it is around income, don't have money to buy the food. So they aren't things we don't know, but it's not just the fact that they're eating the wrong thing. So it really elevates those issues to a point where a local public health department might say, what do we need to do about transportation? How are we going to work with our transportation department? It really forces us to move into a health and all policies kind of thing. Chris, do you have any other high levels from that? Other data that we've seen?
We have one county that's kind of an affluent suburban county, Scott County, and that's the county that Jeanette referenced, that she has, basically we had this really long discussion. One of the components of SHIP is we also required that all of our community health boards do this 11-question survey. It's taking, because we didn't have local level data. So we asked them to we picked 11 questions from the BRFIS, and we asked them to do a survey on the local level. And what we heard back resoundingly was that middle-aged white women fill out surveys, and that it's not representative of the community, and that those 11 questions were not helping them inform their work. So when they went out and did these focus groups, they are getting information back that's just really heartfelt information from the community's experience and inequities every day. And a lot of it has to do with structural issues, with housing. And so I think that people are really struggling with, what can I do within the parameters of the SHIP program? And now I have all of this information, and I think that they're feeling a weight of responsibility to address some of the other issues that are coming out in their focus groups as well. And so it's really helping folks process information, figure out what can they do. Some of that they can do within the parameters of the SHIP program. So it's really us giving them permission to address some of the issues and how to kind of redraw our logic models so that the housing issues are part of our health in all policies, and that housing does impact your access to food and your physical activity and all kinds of other things. And so it's us sort of being permissive as a funder, but then also helping them reframe things and learn how to communicate that to their local stakeholders and just kind of what to do with that information, because I think that people are in a new space of not knowing what to do with that information.
So I want to say, in addition, I'll give you another example of some data that was collected and an action that was taken. In addition to the big systemic things like housing, et cetera, in this same county, in Scott County, they did some conversations with the Latino community. And one of the things the folks said is, our kids love to play soccer. And for some reason, at 8 o'clock when the sun goes down, the soccer fields don't have lights on, but the hockey rinks do. Who uses hockey rinks? Who uses soccer fields? And so it's sort of elevating some of those issues to a place where people can see them. And that's actually, it's not a totally simple fix, because then they came to us and said, well, can you pay for lights on the soccer field? And then we have to make a decision about whether we can do that or not. But there's other resources to pay for lights on the soccer field, right? So it's elevating those issues to a place where they're actionable. I will say, like, I'm hoping one of the changes that will happen, this is totally my perspective, so Chris, you can shut your ears. A lot of our active living revolves around bicycle riding, and there's only so many people that own bicycles, can ride bicycles, et cetera. And one of the things that we're finding is that the very assets the recreational assets that communities have are not being used by communities of color. So in Brooklyn Center, over 50% of that community is communities of color, African immigrants, Asian immigrants, Latino immigrants, and but the community center is only used pretty much by white people. So that SHIP project did a cultural liaison kind of thing where they had weekends that opened up that community center to, like, they invited folks in for those weekends to the community centers. The community center director was there with a translator. There was a conversation. They did cultural humility competency training with the workers there. And after that, this is a one-time project, which they're going to continue, but after the one time of having 3 weekends, one for each cultural group, over 50% of the swimming lesson slots were taken up by people who had come to those sessions. And our drownings in Minnesota, like if you're concerned about public health drownings, are either inebriated older white men or young people from immigrant populations who don't know how to swim. So, any other one? That was a long two. So we'll take 2 more questions and then we'll move on. And there'll be some more time for questions at the end.
Hi. Going into your thread on health and all policy, can you give an example, once you've identified, health being affected by factors like housing or transportation, how you've been able to engage those departments to help in your initiatives?
We actually have a really robust partnership with the Department of Transportation already. And there is a statewide effort right now to develop an active transportation plan that includes walking, biking, and other things. So in that arena, we're doing really, really well. Susan mentioned the Healthy Minnesota Partnership. If you can Google you can look at the Healthy Minnesota Partnership. We have a cross-sectoral partnership that actually involves Department of Transportation, Department of Corrections, Department of Human Services. There's another state department. Anyway, so we are working really to build those relationships. I think with SHIP, the real opportunity is how are we working better with the Department of Natural Resources, which runs all our state parks? How are we working with them? So I can tell other health and all policy stories that don't relate as much to this. I think we haven't quite gotten there yet, except with those really strong relationships with the Department of Transportation. Is that true?
Yeah, I think that's true, and I think that housing in particular has been really challenging for us because that does come up a lot, and we are just starting to have conversations. We've seen some other areas of the country where an example is that they have incorporated access to legal aid where they fund a part-time person to come and help them with landlord issues or those sorts of things. And I think that we would be open to the conversation about could our dollars be used to fund someone part-time for that or contribute to a fund. I think we would be open to that. We haven't had anyone take us up on that yet, but those are the kinds of conversations that we need to keep having around the state.
So that was the other department that's on the Healthy Minnesota Partnership, is the Department of Housing. And we've been working with them for them to actually shift some of their policies to think a little bit more about healthy housing. Housing policy, there's somebody at this conference that really knows a lot about it, is extremely complex, and there have been very little increase in public funds for subsidized housings, for like decades. So we're really stuck in we're really in a not a great place. But we are thinking about housing. The other thing that SHIP folks have been doing, if your communities have comprehensive planning processes, they've been inserting themselves in those tables to sort of think about transportation, healthy eating, active living as part of the comprehensive planning. So they're bringing that lens to that table. And I think there's one other question, and then we'll talk about the tribal stuff. And then we'll have time for some questions at the end, I think, too.
Could you speak a little bit more about the capacity building you did with the public health directors around the health equity practices?
Yeah. So, again, we've had this health equity effort for many, many years. And I think there's a tendency in government to say, this is the new thing. We'll just hold on until it's over. Or we'll give our attention to it a little bit, and then we'll wait till it's gone. And I think... And that's people's experience too, right? Like there's a new administration come in, there's a new wave of stuff, you try to do a lot of things. In this case, and health equity was treated that way too. I guess I actually really believe that health equity, you have to change like almost everything you do, or you have to change the way you do things. You don't just do one or two things and, magically we have health equity. These are really about systemic. It's a very complex issue. So we've had early adopters in our local public health departments who have really advanced things. There's a great project through SHIP that's, working with family, friends, and neighbors childcare. They've developed a Latino hub. They've tried to impact the county's policy of not having daycare training in Spanish, only in English. So, you run into all these systemic things. So there are some places where local public health directors have really adopted this. One of the challenges we've had is Minnesota is 80% white and 20% American Indian and people of color. So many of our local public health directors literally have counties that are 98.5% white. And we have led with race in our equity efforts because that's where some of our greatest disparities are. So they don't think it applies to them. So there's been some problems from our end, sort of saying, how are you engaged to this? But there's also been resistance, and some of them have very, very conservative county boards, and so it's really hard for them to advance equity or even use that word. Our own commissioner, when he was promoting this through ASTO, got resistance from some states saying we cannot use that word equity. And so we have some similar political considerations. The other thing is that most of our public health directors, our older ones, come from a public health nursing background. It's very much an individual intervention. They don't have a lot of experience with engagement. It makes them uncomfortable because it actually points out some of their growth areas. And so there's also sort of that. They don't actually know it. So we are doing this cohort with six local public health departments. We also have found out that we don't know how to coach on this yet. So we're learning a lot about how do you coach on this. So that's a very long answer, but there you go.
Okay, I'm going to talk a little bit about a different process that we used with our tribal nations. In 2013, I was asked to take a mobility assignment and go to our tobacco unit and oversee. They had a supervisor leave, and they had just ended a 5-year grant period, and they needed to renew grants and get things back out the door. So as I was, and also one of my first tasks was, and there's a legislative report due, so could you write that? So I thought, I'm going to just go read all of these reports, and I'm going to pull information and put together this legislative report. And when I looked at the tribal reports, there just wasn't much meat to it. But I had been to meetings where I heard about good things that were going on in the community, and yet our reports were showing that they were serving like 3 people. And I thought, well, are we counting the right thing? What is this about? So I started calling the tribal health directors and just having some conversations, and pretty quickly discovered that how we had built the tribal programs was that we took our menu of strategies from our community health boards and said, here you go, what do you want to do? Pick from this list. And that wasn't working very well. And so one of the first things, you'll notice in here that I said that we're working with 10 tribal nations, and there's more than 10 logos up here. So all 11 tribes agreed to participate in a year-long stakeholder process with us, as well as 2 of the main urban organizations as well, Onday Young and Division of Indian Work. Because I basically went to them and said, I'm going to say that I don't know what I don't know. I don't think that we've set you guys up for success, and I think that maybe we need to take a break. And we just had some really honest, we had one-on-one conversations. We also had some conference calls where we talked about what should we do, because there was this sort of looming deadline of your contracts are ending and we don't want there to be a gap in funding. So what are we going to do? Because now we know that this list of strategies isn't working for you, but I have like 45 days to get something out the door. So what we agreed to was this 1-year kind of pause in activities. So they continued to do the activities that they were doing because they didn't want the work to come to a screeching halt for a year, but they just scaled back, and they committed to having a representative work on this stakeholder process with us. And I also recognized that maybe I wasn't the best person to lead this process because I had not done tribal work before. And just because I was the supervisor didn't mean that I was the right person to go out and have these conversations. And so we agreed to hire an external, kind of neutral, culturally competent, trusted contractor. So we did an RFP, and we asked the tribes to help us review the applicants and select a contractor that everybody was comfortable with to lead us in this year-long process. So we ended up going with the Great Lakes Intertribal Epidemiology Center as our contractor, and we set up this process where we had an advisory group, so representation from all of the tribes and the 2 urban organizations. And the format that we used was that they did key informant interviews. So the role of these advisory committee members was to identify who to engage in their community. So we knew that tribal health directors were a given, but who else? Who are the elders that we should be speaking to? What are the professional organizations on your reservation that we should be talking to? What are the other programs and community members? And so we did lots of key informant interviews. We also did dynamic group interactions for feedback. It's like a focus group, but it was a cultural focus group that Great Lakes Intertribal Epicenter came up with, and it has a visual component to it. So they built a picture of the community that they wanted to move towards. And then we did some surveys too, because we're public health. The focus of the interview, the inputs, was around the menu of strategies. So what should we be doing in your community if this current menu isn't working for you? And then also about our grants process. So as long as we're out here, let's ask you about how are our contracts working for you? How is our reporting? What's the evaluation feel like for you guys? So we kind of had this two-pronged approach. And then the deliverable after this year was that we would have a set of recommendations that would be presented to our agency. So one of the first things that came out that we learned was this is our new logic model for our tribal health work. Culture is at the center, and it's more than just culturally adapting like, oh, here's the program that we do with our local counties. We're going to culturally adapt it, and we're going to do it in your community too. It was deeper than that. It was about just healthy, culturally healthy, connected people are resilient people, and they're a strong community. And so it was allowing our grant funds to be used for things like we sponsored a GONA, a Gathering of Native Americans, which is a 5-day intensive process where you bring community members together, and it's focused on healing from trauma. That's what the tribes asked us for. And so even though our statute says physical activity, healthy eating, tobacco use, we know that all of these resilience factors are going to help all of those issues and other issues like suicide in the community and other things that they're dealing with as well. They also asked us for ACEs training, so adverse childhood experiences. I would say pretty clearly that you shouldn't go out the box and just offer these to the communities. The communities should really ask you for these things. It's not our place to say, oh, you need to heal. These were things that the community asked us for. And so we really leaned on the community to say, well, who does this training? How do we do it right? And we really just provided the funding and let them take the lead on what's that going to look like in your community, which was very new for us. So other things that we learned throughout this process were that really all of our work should be rooted in American Indian culture, and that culture and community building are assets in creating health. Really the importance of mutual understanding and respectful relationships, the need to promote healing, which I already talked about, a recognition of strength and resilience in the American Indian community, so assuming that they come from a place of asset and that it's not just detriments in the community. I think that the way that some of our materials were framed were all about, oh, there's a 59% smoking rate, the obesity rate is this, diabetes is very hard in the community. And this was about, let's lead with the assets. Let's talk about what's going right in the community and build from there. They really talked to us about developing programs that are culturally rooted, strategies that are culturally appropriate and realistic. So when we went through that original menu of strategies, some of the things that popped out were around tobacco. That was a big one. Some of the examples that came out in our key informant interviews were that in our tribes in Minnesota are Ojibwe and Dakota, and they use tobacco in a sacred way, and they offer tobacco. They say that they start the day with tobacco, and one of the things that they saw was very common is that for funerals, you're supposed to, it's traditional to offer tobacco, to put tobacco in a basket as you come in for the funeral. And what they were seeing was that people had, over time, transitioned to, those baskets were filled with cigarettes, because that's what they had access to. They didn't have access to traditional tobacco anymore. And so the tribes asked us to adjust our menu and to add a strategy that was called Increase Access to Traditional Tobacco. So we are allowing tribes to use grant funds to help them plant medicine gardens and to replant red willow and acema, which are the tobaccos in Minnesota, so that they can increase the plants and actually have access to traditional tobacco, because they don't like to see cigarettes in those baskets either. But they didn't have access to those medicines until, I want to say 1974, when the Religious Freedoms Act was lifted. So those are the things that I had no idea going into this process, and they seemed to make a lot of sense, and they were they were easily incorporated into our menu. Around active living, some of the things that we learned were, again, all of our strategies were around walking and biking, and we pretty quickly learned that there wasn't the infrastructure for that in the communities. They said that things were very far apart, so if you know anything about reservation land, it's not like, oh, here's the reservation. It's here and here and here and here, and there's multiple villages or districts, as they call them. So they're very spread out. So to think that we were going to just have walking trails to connect everything wasn't really realistic. And then in some of the communities, we heard that there was an issue with dogs in the community, and people didn't feel safe being outside. So we really wanted to talk about, well, how can we address the dog issue? What's within the parameters of our grant program that we can use funds for, or that we can always be a convener, and so sometimes that's the role that we end up taking. So those are some of the big examples that we changed in our menu. So this was a long process. This work takes time to do it right and to listen. We did the stakeholder engagement process in 2013, and then we took almost a year to stay true to our community engagement model and really work with the tribes to rebuild that menu of strategies. So listening to them, like what should be on there, and then we'd draft and we'd go back and we went back and forth. We also talked about our funding model and the tribes. We have some very large tribes and we have some very small tribes in Minnesota. So we wanted to talk about what's the right way to distribute this $1 million pot of funds. And the tribes really, like, they gave us the funding model. They said, well, I think that we all need a $100,000 base because you need a full-time person and you need these supports, and then could you just do per capita? And so really talking to the community and coming up with solutions together. So they hired staff in that first year, and then really they wanted to talk about evaluation, and it's in our statute that we have to do evaluation. So we went back to those reports and said, how were we not capturing the good work that was going on in your community? What's the right way that we should be doing that? And acknowledging and recognizing that evaluation in the community has not always been done in a respectful way. And so asking them, what have you seen that's been done right? Who are the evaluators that you trust? And again, we ended up doing an RFP, and the tribes helped us select an evaluator. So we're now just beginning to work with North Dakota State University, Dr. Donald Warren, and their American Indian Resource Center. And so they are using an indigenous evaluation model and going out and having conversations. They're going to develop 10 different evaluation plans because they are sovereign nations. And so the notion of us having one evaluation plan wasn't even the right approach to take from the beginning. So just a couple of examples of how we're doing things differently. We're working with the American Indian Cancer Foundation, which is a national organization. They are based in Minnesota, so we're lucky about that. But they are really, things are very visual in the community. They wanted more infographic type things, but they wanted them indigenized, they told us. And so this is really looking at our work in the community. So you've got the community tobacco garden, and you've got the tribal clinic, and so it's got the pieces of the community that they recognize. And so it was really creating some materials that really speak to them as well. Okay. And then just 2 more slides. This was through our process. One of the folks that helped us through the process was John Poupard, and he was the former president of the American Indian Policy Center, and he's also an elder in the community. He was also a longtime Department of Corrections employee, so he's a state employee as well. And so a lot of what he said really resonated with me. And I really took this quote in particular, that 2 schools of thought exist, one for government and its institutions that is linear, because we always have to have an agenda. We have our menu of strategies. We have our logic model that is linear, usually. And the other is for Indians, which is holistic and cyclical, and a bridge for understanding between the 2 domains must be developed. And that, I just always try to remember that now as we go forward in our work, and we're constantly consulting the community. What should we do? How do you feel about this? Is this the right approach? Help us. And then this is just from one of our meetings. So one of the things that we learned was that we should be out in the community. They said you need to add another grants manager so that you can come out and be in our communities and understand us better and see what challenges we have and what assets we have. And so we have one of our annual meetings out on Lake Bemidji, and this is the group. We just had ceremony inside to start the day, and they were going out to offer tobacco to the lake. So are there any remaining questions? About any of the comments? Yeah.
This appears to be somewhat of a pilot where you're still waiting to get data in, if I understand correctly, but it seems to be potentially a framework that could be used for all different types of communities. So I was wondering, have you had any plans to extend that to other communities in your area?
Yeah, so that's a good question. I think that, so most of our work is focused on our grantees, and the tribal grants program is the only grants program where the funds go directly to the community. I think that one of the things that we're starting to talk about is kind of the next iteration of the SHIP grants, and those grants right now go to the local county health department, but a lot of those local county health departments are doing mini grants to communities. And I really want to move away from that model and have better investments in community, and rather than throwing $2,000 and $3,000 and saying, checking a box. And so I don't know what that's going to look like yet, but that is definitely an area that I want to address.
Actually, there's another program within OSHI. There's a tobacco program.
Oh, yeah.
And they actually did a similar process, going to the communities who were experiencing the highest inequities in cigarette smoking rates, and really then crafting those grants to meet what people really wanted. And one of the things that came out of that, because we're very focused on policy systems and environmental change, but the grantees clearly told us we need cessation programs that meet the needs of our communities and the culture of our communities. So we did listen to that and then shifted some of the funds into cessation programs. Is
That's
that
right,
true?
thank you.
Yeah.
I was wondering, earlier it was mentioned that you had to prepare professionals to have the lived experience at the table. Can you give some examples of how you prepared them?
This is really an ongoing process. I think, so one of the things that I've been advocating for our folks to do is to actually talk to people directly, especially people that they think may have problems with it. So there is that sort of one-on-one, not only with the people that you're bringing in, but the people that you already have at the table. We haven't cracked this nut yet. I'll give it a, so I oversee a lot of the community engagement work at the Department of Health, and we're meeting with people who run advisory groups. And our public health labs had a process where they generally have had doctors on their advisory groups, but now they're bringing in community members. The doctors had just been to a national conference where they were getting all the latest about what should be done. And when they brought it back to this bigger group, the bigger group said, no thanks, but no thanks. And so the group actually made a different decision than the doctors wanted. After the meeting, not at the table, the doctors called the staff and said, that was way too emotional a decision. Like, people weren't logical enough because they didn't believe what the research had said. So it's a big challenge. I think one of our challenges in public health, we really have an expert mentality, like we are the experts. I actually just did a piece because there was in Ramsey County, which is where St. Paul is, the folks have done a really good job there. And some of the things that they've done are their public health director comes to every meeting. And they say that meeting that the community is involved in is extremely important. Secondly, the staff actually greet people as they come in the door. They provide the opportunity for people to talk about lived experience, and they affirm it. So part of it is, in some ways, credentialing lived experience as valid. So they've created a culture of that group over time through staff leadership and through sort of the public health leadership saying this is important to create that kind of table where everyone's voices are welcome. So it does take time. It takes preparing the people who have been there, and it creates really demonstrating and modeling a different ethic. The other thing this guy said, he was really good. He said, watch for your body language, because we never condescend to anyone verbally, but we also don't want to do that in our body language. So I've been realizing as I've been trying to coach people around group work that is extremely complex. There are many, many facets of it. It's supposedly one of the core public health competencies. We have a lot of work to do there. I don't know if that's helpful.
I'm just curious about how you're going to demonstrate, change in a quick enough time frame that your funding won't be, at risk, because that's always the problem. It seems like with these wonderful health promotion, disease prevention, they don't demonstrate change quickly enough and the funding goes away.
Yeah, that's actually a really good question, and we hear it every single year at the legislature, is that they want to know, have we reduced healthcare costs and have we lowered the obesity rate? So we're really trying to change the narrative around, steer them away from those questions and talk about results-based accountability. So what's our contribution in that giant space and those giant measures? And then also just to talk more about the complexity of obesity and food systems and all of those things. So even when we got our new obesity rate, we in the BRFIS this year, when that came out, we had done 3 months worth of prep work around some other questions that are in BRFIS around economic hardship, and trying to do some crosstabs around why do we think that is? Let's not just focus on did our obesity rate go up or down, but let's look at this complex system. And in Minnesota, when you look at the obesity maps, thankfully, right now, we're a color that's different at a lower obesity rate than all of our surrounding states, and we're the only state that has this sort of full-scale program. So we're kind of talking about we're holding steady, and that's a win, and here's why, and here's all the complicating factors. So we're really trying to get away from just one measure, but talking about milestones and the complexity factor and what's our slice of the contribution.
I would just say one other thing about this program as we wrap up is that it is statewide, which makes a difference, and it also is providing economic development. I mean, so even though some of the commissioners don't actually like the model, they do like the fact that bike paths are being built, infrastructure is being built, their schools are being supported, and it becomes politically a lot harder to undermine. And this thing about what is our role using results-based accountability is really important. So I think we're done.